I'll start by laying out the parameters of the study so that the viewers will have some context. We'll start by saying that the average lifespan of a glioblastoma patient is roughly 8 to 15 months. So you, Dr. Seyfried, were one of the authors on a recent publication that tracked 18 glioblastoma patients. Now, of the 18, 6 followed a ketogenic diet for at least 6 months. All 6 of the diet-adhering patients lived at least 33 months. One of them has been living with GBM for 84 months and is an active teacher. Of the 12 patients who did not follow the diet, just one of them lived more than 30 months. So, Dr. Seyfried, what is your initial reaction to this publication?
Yeah, well, thank you, Kyle. This study was done by a group of people from Greece. I'm a friend and knowledgeable of Dr. Athanasios Evangelio. We worked together in the epilepsy area years ago. I have a lot of confidence in his ability because he is one of the few people that really understands how to use diet therapy for neurological disease. So he had a publication several years ago where he was one of the first publications showing that ketogenic metabolic therapy could manage autism. And he was working in the epilepsy field for many, many years, has great familiarity with how to design and implement diet therapies for various neurological diseases. When I spoke to him many years ago, I said to him we should start to think about doing this for brain cancer patients. And he was very enthusiastic about that because we had done so much work on preclinical studies on brain cancer. And he was looking at various patients over the years and told me they were able to get a cohort together some years ago that we could follow their success or management of glioblastoma in his experimental design, which I think is better, so far better, with respect to the diet than anyone previously. So you have now, for the first time, a person and a group of people that understand how to use food as medicine and understand the complexities of this approach, whereas many of the other studies that weren't done, where the patients didn't live nearly as long, were not done by knowledgeable people with respect to knowing how to use food as medicine. So I think I have a lot more confidence in the results from this study than I have in some of the other clinical studies. Now, I should point out that all of the patients in this study were wild type, which is the worst case, and they didn't have a singular patient who had a mutation in the isocitrate dehydrogenase mutation. Our patient that we published, Pablo Kelly, we published that also in Frontiers in Nutrition. Pablo lived to be 10 years, longer than any of these guys here, but he had an IDH1 mutation, which I should point out, and they did mention it in here, leads to a longer overall survival for people that have glioblastoma, having that mutation. And then the field went and reclassified glioblastoma with or without the IDH1 mutation. So they call patients who have the IDH1 mutation as malignant astrocytoma 4, whereas the patients that don't have are wild type, that don't have are glioblastoma. So and these names are extremely ambiguous at best. These guys make a big deal out of this. I know this classification stuff. A lot of it's bogus. You could get different results, different viewpoints. When we did our study on our glioblastoma patient, Pablo was diagnosed as a glioblastoma. Okay, I gave the slides to several groups of pathologists to confirm the diagnosis as glioblastoma. So all of these centers call them glioblastoma based on their histology. After people realized that you have a glioblastoma with an IDH1 mutation, they live longer. So we have to reclassify these guys just based on the IDH1 mutation. But histologically, you wouldn't call them any different. They all look very similar. So the IDH1 mutation produces a metabolite called 2-hydroxyglutarate, which restricts the glycolysis pathway, which, as people know, are drivers of cancer, the glycolysis. So if you have a mutation that restricts glycolysis, you're naturally going to live longer. And that was what our patient. Now the difference is there's several different differences. Okay, so the Greek study used only 18 people that did not have an IDH1 mutation. Because if you did the IDH1 mutation, you see it, people would say, you got extra survival because you had some guys that had this inhibitor of the glycolytic pathway, which is the IDH1. So they made sure that they didn't have any of these IDH1 kinds of people, number one. Another difference is that all of these people in the Greek study received the standard of care, which is surgical debulking, followed by radiation, followed by with some steroids and some temozolomide, which is an alkylating agent that causes can cause a lot of diarrhea, inflammation, all this kind of stuff. But in any event, so there were differences between our long-term 10-year survivor and these folks. Pablo never took radiation, never took surgery at first. He waited 3 years, so we changed the standard of care dramatically because the patient himself did not want standard of care. Okay, so let's look a little bit more detail at this, our Greek study, successful application of dietary ketogenic metabolic therapy in patients with glioblastoma, a clinical study of 18 people. And look at what they did. So the patients all had standard of care. That means they had surgery and they had radiation. And despite that, those that could adhere to this diet, which was a calorie-restricted Mediterranean diet, which again was far more palatable and easier to adhere to than some previous other clinical studies where we eat more lard and things that were not as palatable as this Mediterranean diet, which consisted mostly of salmon, sardines, avocados, various kinds of olive oils, and some vegetables. But the meat, the protein came largely from sardines and salmon. It wasn't too terribly difficult. To me, it would seem that people should be able to follow. I could follow something like that. I mean, it's not like salmons and sardines, avocados. I mean, this is not so drastically different, calorie restricted. But it was very interesting. Of the people who adhered to the diet, there was 6 out of 18 that adhered to the diet, and 4 of them survived beyond 3 years. The other thing too, let's look at overall survival for glioblastoma. The median survival today is between 8 to 15 months, which is very similar to what was found in 1926 by Bailey and Cushing. So we really haven't made any major advance in managing glioblastoma in just about 100 years. 100 years, no advance. That's what I always found to be striking, right? Think about it. You got the Webb telescope that's circling the Earth 1 million miles, looking at the origin of the universe, and we still haven't made any advance in managing glioblastoma. Why is that? Well, first of all, the tumor is aggressive. There's no question about that. If you don't do anything, you could live to be 8 to 15 months if you don't do anything. Now, if you have standard of care, which is surgical debulking, followed by radiotherapy, together with temozolomide, you can live maybe to 17 or 18 months. Maybe you could push out 24 months, but not much advance in doing those things. So we published a paper in 2010 in Lancet Oncology, and we followed this up with more recent papers. Why is it that these glioblastoma patients don't survive for very long? And the answer is because of the treatments they receive. We now know unambiguously that these tumor cells are driven by the sugar glucose and the amino acid glutamine. Those are the two predominant fuels that drive the dysregulated growth, and we know they can't switch to ketones or fatty acids. We have done this over and over and over again and looked at dozens and dozens of studies. So knowing that the tumor cells thrive on glucose and glutamine, then you treat the patients with radiation, and radiation drives blood sugars through the roof. Radiation by itself makes the blood sugar go very high. When you irradiate the brain, it gets hot and swells. And in order to reduce the swelling, you give steroids. And steroids, like dexamethasone, also elevate blood sugar. So two of the procedures that you are using, radiation and steroids, elevate blood sugar, which is the fuel for the tumor. When you debulk glioblastoma, that means to surgically resect it, almost invariably, you never get the whole tumor. Almost all surgeons will say, we got most of course you got most of it. You got whatever you saw. But it infiltrates into the local area and you can't see that. And the tumor cells migrate to distances away from the central mass, and you never get that. So they always say, oh, yeah, we got most of it. Of course, you get 95, 98%, but you left 2% that'll come back and kill you. Now, you take the tumor out, you create a wound. As soon as the patient recovers from the wound of debulking, you then give them radiation, and the radiation makes the sugar go through the roof, and you give the steroid to reduce the swelling from the radiation, and that makes the sugar go higher. And not only that, when you irradiate the brain, you have a tendency to break apart. There's special connections between neurons and glia in the brain that have a glutamine-glutamate cycle. I'm going to go into the neurochemistry. You just have to know about the neurochemistry of how your brain works. When one neuron signals another neuron, it secretes, releases a neurotransmitter called glutamate. Glutamate is an excitatory neurotransmitter, and it goes from one neuron to the other in a gap, but it has to be removed as quickly as possible. Otherwise, it will create a seizure, and the glial cells take up the glutamate and convert it back into glutamine and then pass it back to the neuron. You have this very tight cycle. When you surgically debulk and irradiate, you break that cycle. You free up massive amounts of glutamate, which are excitotoxic molecule. The glial cells will now take up the glutamate and convert it back into glutamine and dump that into the microenvironment. Any tumor there is going to suck down that glutamine like there's no tomorrow. So between the radiation, the steroids, and all of this stuff, you free up massive amounts of glucose and glutamine in the tumor microenvironment based on the surgical procedures and the treatment you're doing to these patients. I told you, if the tumor cells need glucose and glutamine as the prime fuels, and you create an environment enriched with those two fuels, what is the outcome of that procedure? Death. And that's why when you look at survival curves, they're so horrible and they haven't changed in all these years, because you keep doing the same thing over and over again, reducing the ability of the person with the tumor to have long-term survival. In our individual, Pablo Kelly, he never had radiation or chemo. He had only surgery and diet. And he lived for 10 years, and he died from his fourth surgical debulking from a cerebral hemorrhage, and nothing to do with the cancer. In this new study, the physicians here were forced or had to do standard of care. So their patients were debulked, irradiated, and given temozolomide. Despite that, the diet that they used was able to successfully maintain viability in several of these patients that maintained the diet. Only one died before the 3 years. The others made 3 years, which already is twice as long as you would have it if you did standard of care without this ketogenic metabolic therapy. So 15 to 16 months is the median survival for people getting standard of care, and now you've introduced a therapy on top of standard of care, and we're able to double the survival, even more than that. That's quite remarkable. I think that's because the people doing this study, number one, are very knowledgeable about how to use diets. They used a Mediterranean, calorie-restricted Mediterranean diet. The interesting thing is the people who did not maintain the diet, only one of these people made the 3-year survival, whereas 4 out of 6 made of the people that could maintain it survive for the 3 years and longer. So the question is, why did these people not maintain the diet? And the answer is quite interesting, because I always thought it would be the palatability, but it was more like he has a nice, you can look at each one was kind of different from the other.
An attempt was made to uncover the reasons why these patients ultimately did not follow the diet. One potential reason for non-adherence to the diet in certain cases was the strong desire of close relatives to avoid discussing the seriousness of the diagnosis and the unfavorable prognosis with the patients. This applied to 3 of our patients who had already undergone surgical resection, radiation, and chemotherapy. They felt reassured that they had done everything possible and saw no need to adhere to a demanding diet. Another reason was a lack of trust in the diet. 4 of our patients did not believe that following conventional therapies, a simple diet could be beneficial, despite initially agreeing to follow it.
In order to survive, you have to be knowledgeable and work with the medical staff. The medical staff needs to know what to do, and the patient needs to be educated to know what to do and work with the group. And I think that can account. Now, here's my take on this whole thing. This is only the first step. In my opinion, if we were to use what we now know how to manage glioblastoma, we've written papers on it, we've done preclinical studies on it, don't do radiation. I would say this is contributing to the demise of these patients. You don't do radiation. You do metabolic if you have an opportunity for a watchful waiting period, and sometimes you do, sometimes you don't. That's a call by the neurosurgeon. You shrink that tumor down using metabolic therapy, water-only fasting or restricted ketogenic diets like this. Once then you debulk the tumor, and you will get more of the tumor. The tumor will be less inflamed, less angry because of the metabolic therapy. And then once the tumor is debulked, you now move in with this kind of a keto and targeting glutamine now. These guys did not target the glutamine. Can you imagine how much longer they would live if, number one, we didn't do radiation, and number two, we targeted glutamine at the same time we're doing this diet? I predict, you can test me, they run a clinical trial, see if I'm wrong, we'd get 4 and 5 year survivals. Not 3-year survivals. We get 4 and 5-year survivals. The tragedy is the field cannot accept what we're saying. They think you must irradiate these people, even though the radiation will free up the 2 fuels driving the dysregulated growth and contributing to the recurrence. We have published this. Others have published this. Why would you treat another human being with fuels that are going to make the tumor grow faster? Makes no sense. So something has to change. This is only the first step. So the next step would be, let's not irradiate these people, the GBM, and let's give them glutamine targeting drugs at the same time we're using this restricted Mediterranean ketogenic diet. What is wrong with this? Someone has to go to these, and I went there, I gave them lectures, and they seemed to, it was like they were deer in headlights. I don't know. They were staring at you. They almost couldn't understand what I was saying. Don't irradiate the brain. Is that hard to understand? So I think we're going to get much better survival. But the patients have to know this. They want to see the outcome. They want to see their destiny. Have them look at the survival curves using standard of care. It's abysmal. Why is that? Because the very treatments they're doing are contributing to the recurrence of the tumor. But this study is an eye-opener, because there was 18 people. Was a clear difference between those that adhered and those that didn't. And I'm telling you, the ones that adhere, if they don't get irradiated and we target their glutamine at the same time, I think we're going to get 4 and 5 year survival.
What else would an ensuing study look like? So far, we have 18 patients, 6 of them adhered. 4 of the 6 lived at least 3 years. 1 of the 2 that didn't live at least 3 years is still alive. So it may end up being 5 out of the 6 who lived 3 years. You're saying don't give any radiation and add a glutamine inhibitor. What other parameters would you like to see?
Well, I think we're learning more about educating the patients. Like there should be no reason why you would fall out of the study, especially if the diet is palatable. And if someone can't eat sardines or salmon, they might have. We can always substitute it with lamb and beef or something like this. as long as they would have a low carbohydrate diet structured to meet their palatability needs, because you definitely don't want to. There's so many flexibilities you can have in the way you can prepare a low carbohydrate ketogenic diet. You get your GKI, glucose ketone index, which they did measure in their patients. So that's another standard. Keep low GKI, a restricted ketogenic diet that is palatable, whether it's a pescatarian, Mediterranean, carnivore, it doesn't make any difference. It might be a little bit more difficult with vegan diets, people who have to eat only plants. It can be more difficult, not impossible. You eat one cell restrict once every 3 days, you might be okay. But you have to get your GKI down. And then you see how much longer. Now, the problem is the people who run the oncology clinics would have to say, okay, we're going to throw out the standard of care and we're going to make a new standard of care based on cancer being a mitochondrial metabolic disease. And the authors of this paper clearly understood that. They understood that cancer is not a genetic disease, it's a mitochondrial metabolic. They say it right there. It's a mitochondrial metabolic disease, and keto therapies lower blood sugar, elevate ketones, which the tumors can't use, okay? But they still have that glutamine issue that they didn't target. So if we used a small amount of 6-deoxynorleucine, which is DON, D-O-N, it's a glutamine analog. So here's the situation. The tumor cells are getting their glucose, but it's restricted by the diet, but they're able to get some small amounts of glutamine. So DON looks exactly like a glutamine molecule. The cells are excited to get it. It goes in and gums up. It shuts down the whole pathway. So all the ability of that cell to use glutamine is all blocked up by this DON. So now they're starving. They don't have the glutamine. The diet is reducing the glucose. The normal cells are getting healthy because you're turning everything over to ketones. People are going to live longer with a higher quality of life. It's just that simple.
Regarding DON, the times that DON has been studied, they've said that it was too toxic for human use. Would you say that we'd be better off using a DON prodrug to try to mitigate some of the toxicity, or would you rather use the original DON molecule?
Well, we showed that we published a paper showing DON administered with ketogenic diet, you don't need nearly as much, and you reduce the collateral toxicity. It's just like having a new drug. You don't have to go with a prodrug. You can go with a prodrug. But why not go with the regular drug? You're going to get the benefit, and you're going to reduce the toxicity. What's wrong with that? So they keep saying, we can't use DON because it's too toxic. Yet they're giving temozolomide, which is toxic. I mean, what are they doing? And temozolomide creates inflammation. DON doesn't do that. So why would you? Let me say something. There's another reason for why we're treating the patients with standard of care, and it's not for the good of the patient. What do you think that is?
Cash.
Revenue. The treatment, that's it is. Radiation, you generate a lot of revenue with this. These drugs, you generate a lot of revenue. Immunotherapies don't work. Okay. Immunotherapies don't work. You know why? Because the acidification of the microenvironment blocks the ability of the immune system to work, the immune therapies to work. Where is the acidification coming from? Glucose and glutamine. The waste products of glucose and glutamine metabolism acidify the microenvironment. You can't, this doesn't work. If you take away glucose and glutamine, the tumor cells die. You might not need this other stuff. Not good news for the patient, not for the industry.
How many people do you think should be included in the next study?
Well, I think if these folks from Greece can convince the people who write standards of care that we have to modify the standard of care and do a study designed to keep people alive, then they would eliminate these obstacles that are causing these poor folks to die earlier. So, and then you'd have to sign off. Listen, if I had a glioblastoma, I'd be doing this. I would have no radiation in my brain. Never do that. It's going to kill me. Why would I do that? It's going to free up glucose and glutamine. It's going to make everything else less effective because of that. So if I don't have glucose and glutamine buildup and I can control the acidification and I can kill those tumor cells with diet and drug that are going to starve them to death, well, I would definitely do that. At least I know that I died if I died, I would die from the tumor. I wasn't going to die from the treatments that they're giving me.
Would you like to see a study of glioblastoma that includes hyperbaric oxygen and mebendazole, or would you rather just study DON and diet together?
Well, the mebendazole is a parasite medication. We have a paper already published showing that it can target a little bit of glycolysis and glutaminolysis, the glucose and glutamine pathways. Not as strong as DON, but it's another drug. We have now so many different drugs that we could mix and match with these diets to really, really make overall survival much, much longer. We don't know if anybody would be cured for sure, but we simply know if you can survive 5 years, that would be a monster achievement for them. In other words, make 5 years survival the standard rather than the exception. So can we do it? I think so. The obstacles are not scientific any longer. The obstacles are the institution. The institution is the obstacle, not the science. The institution is blocking us from utilizing the science to kill these tumor cells. Can you believe it? That's what's holding us back. You either get with the program or you get it the hell out of the way, because this is going to happen. People want to live longer. And if they understand the biology and they understand what we're saying, and all you need is a few people to show you it works, okay? And this study, these guys could live, I think, much longer if they weren't irradiated. So yeah, I mean, this is a first step. What are they going to say? We don't believe the results? Wait until we perfect this. You're going to see all these people. And then there's going to be a massive demand for this. Why? This is GBM, and I mean, you don't survive. You can see that going back and look at the statistics on these things. It's horrible. And it hasn't changed in 100 years. And now you have something that comes along. Oh, we can't do that. You can't. What are you telling me you can't do that? Why don't you ask the patient whether they can do it or not? And if the patient doesn't want to do it, that's their choice. Shouldn't be the choice of the system to tell the patient you can't do that. Patients should say, I want to do this or I don't want to do that. That should be the patient's choice. Why the system with people that don't understand the biology and biochemistry making a decision for somebody else? Doesn't make any sense.
How do we go from the results of this study in Greece to implementing ketogenic metabolic therapy in the standard of care? You referenced the STUP protocol. I think
STUP protocol is a death certificate.
Right, but I'm talking about like bureaucratically, technically, how does it work where somebody puts out a study, they say, okay,
you have to, we tried that in some clinics here in the United States, the IRB, the Institutional Review Board, that makes a decision on how you can treat patients. No, you have to do standard of care. Why? Well, that's the way we do it. Why? Oh, just we have to do it. Well, don't you think of the data? Don't you understand what's going on? No, we have to do that. It's not written in granite. Why is the standard of care written in granite? Now, the poor cancer patient doesn't understand. You know, you go to a beautiful Dana-Farber, MD Anderson, where the hell you're going, it looks cool. Look at all these guys walking around with ties and white suits. They must know what they're doing. Well, you got all these people dying. Obviously, they don't know what they're doing. If they knew what they were doing, how come the 15 months survival on these things, right? I mean, here you have a study that says you can live over 3 years if you just eat sardines and salmon, for crying out loud, and get your blood sugar down, your ketones up. Can you imagine if we were to perfect this? We'd keep these people alive a hell of a lot longer.
Yeah, and one thing I found encouraging is that we don't even know how many grams of fat, carbs, and protein that the subjects ate per meal.
But that's why we use the glucose ketone index calculator. It's a quantitative measure to know, and every person themselves can use that and know what they can and cannot eat. It's not, oh, should I eat this? What can I eat? I don't know. Everybody's different. What does your glucose ketone index tell you, right? Once you get free Libras for glucose ketones and the blood prick and all this other stuff, you're going to measure. Every person is a different metabolic situation than another person, right? So every person will know what their GKI. You get your GKI, glucose ketone index. People say, what's a GKI? There's 1,000 web shows on GKI, just glucose ketone, and they have everybody showing you out there what to do. We developed that here at Boston College. Okay, so every cancer patient should know what their GKI is on a daily basis. Eat a sardine and see what it does to your GKI. Okay, drink Coca-Cola. You find out what it does to you. You're going to say, don't drink Coca-Cola. Oh, okay. Infamil. They give Infamil, right, to these cancer patients. Watch what it does to your GKI. You know, so all this stuff has to be known, and it's a work in progress. The problem is, what are we doing? Why are we continuing to do this for 100 years? How can anybody feel good about the brain cancer field? It's abysmal, and it's even worse for little kids with brain tumors. We have a therapy we just put out with combining diet with various drugs. that target glutamine, and we were keeping our mice alive. It's unbelievable. Spinal cord invasion and all this stuff. They won't do it in the clinic. You tell me why. You got a mother and father, their precious child there being brutalized by the system. And if they survive, they have brain damage and all this other kind of stuff. That doesn't have to happen. I don't know. It's just brutal. It just doesn't make sense.
I'm having trouble understanding why the GKI is the predominant marker, because let's say you have a GKI of 1, but that comes from 5 millimolar glucose, 5 millimolar ketones. Clearly the tumor would have more access to glucose at a 5-to-5 ratio than it would at a 3-to-3.
Yeah, well, don't forget, when you elevate ketones in the blood, it also restricts the availability of cells to use glucose. So ketones themselves become a blocker of glucose utilization. And then you put exercise on top of that. And your muscles now start to suck the glucose out of the bloodstream. And it will lower a little bit of glutamine, but not enough to kill the tumor. You have to have the drug in there. There's probably many other drugs that would be quite effective in targeting glutamine. So we would have all that packaged in. Yeah, this is a manageable disorder. I feel so bad that all these poor people, when they're diagnosed with glioblastoma, they already, they can pay off their life insurance thinking that they're not going to survive. This is nuts. So we got to keep these people alive with a higher quality of life, and we can do it. We can do it, and we're the ones that started all this stuff, for the crying out. Nobody was doing this before us. And this is just the tip of the beginning. Wait till we perfect this, and it's going to not only work for GBM, it's going to work for all these cancers. We published a paper. We showed they're all dependent on glucose and glutamine. Can't live without it. This is the thing. So how long is it going to take the people in the country to know about this, in the world to know about this? I publish these papers. I do these interviews. What are they? And they go and they run down there and they get nuked and poisoned. I don't know what's going on.
Do we know if in the paper, the investigators of the paper tracked the glucose daily? Do we know if they did it twice daily, 3 times daily?
I don't know that. In our guy, Pablo, people can go and look at him. He was doing 2-3 times a day measuring his fingers were a little bit raw from sticking the finger all the time, but the idea he was very religious in the way he did that. He was very consistent, and then it was good because we have 5 years of data on that one person. No radiation, no chemo, just metabolic therapy, and he was doing quite well. But the tumor never went away. He was never cured. His tumor just remained indolent, so it grew slowly. After 3 years, cut it out. Okay. Then he saw that the doctor, at first it was inoperable. Wow, I have an inoperable tumor. So we said, well, don't operate on it. If it's inoperable, don't operate on it. So he went 2.5 years, and it got a little bigger. Now now we can operate on it. Okay, he took it out. How'd you get? Oh, we got it all. Wow, Pablo's all excited. So he goes out and starts eating pizzas and stuff that he didn't eat before. All of a sudden, we do an MRI and we see it back again. I put the fear of God back in him. Boom. And for another 3 years, tumor grew very slowly, and then he took it out. Boom, take it out again. Great. In the meantime, he gets married, has a couple of children, and he does a third. And then on the 4th surgery, we were talking to him a week before he died. He was fine. He could have outlived me, for crying out loud. And then he had a cerebral hemorrhage from trying to get the last little bit of that tumor out of his brain, and 12 hours later has a cerebral hemorrhage and dies. How long would he have lived doing metabolic therapy? I don't know, but he was certainly healthy. The only thing he couldn't do, he couldn't feel the forefinger and thumb touching. If he didn't see it, if he looked at it, oh yeah, it's touching, but he couldn't feel it. That's the only adverse effects? Give me a break. I mean, compared to the adverse effects of this, I mean, what you're doing in the standard of care, getting poisonous chemicals and surgical mutilations and all these kinds of things. Yeah. But I think that the future is very bright for glioblastoma. I think the future is extremely bright for all metastatic and advanced cancers if you treat it the right way. We're not treating it the right way. Right. Once you treat it the right way, you're going to see remarkable advances. And it's not going to be so debilitating. Get back. Oh, what happened? I got a cancer diagnosis. Oh, well, take care of that with a metabolic therapy. At the end, go in, get rid of it a little bit. You don't say it's going to die. Oh, I feel it. These poor people are dying as much from the treatments as they are from the disease. So what's going on with that? So I don't know. It's just not a good situation, but it can be much better, much better.
Speaking of how you would treat it using any elements of standard of care, off the top of my head, I think most of the patients received somewhere between 100 milligrams per meter squared of body height and 200 milligrams of temozolomide per meter squared.
Yeah.
Do you have any thoughts on those quantities?
If we can manage to keep the cancer managed, you can lower the blood, the temozol. You can lower the amount. These drugs will become much, much more powerful if you have them in a ketotic state. We showed that. We could cut down the dosage of DON significantly when the mice were under ketosis, and it also facilitates the delivery of the drug right through the blood-brain barrier. We showed that the metabolic therapy will facilitate delivery of drugs through the blood-brain barrier. Why are we spending $1 billion to figure out how to get drugs through the blood-brain barrier using all these crazy drugs when you can do a ketogenic metabolic diet to facilitate the drugs through the blood-brain barrier? Doesn't that seem more reasonable than trying to figure out ways to bust the blood vessels and force drugs through, creating inflammation in the tumor microenvironment? Don't make any sense, this stuff. Most of the stuff these people are doing makes no sense, and yet they do it. And investors think it's important, too. We should educate the investors to know, why are you putting your money into these dead-end issues?
I'm just going to read this one question from the study. I don't know if it'll go anywhere in terms of a useful answer, but we'll find out. It should be noted that all adhering patients, with the exception of patient 1, continued intermittent chemotherapy. Therefore, the first question that arises is whether the ketogenic state contributed to the longer survival due to its effects on cancer metabolism by potentiating chemotherapy.
Yeah, well, it could. It could. I mean, we're not saying it couldn't. We'd have to do a further study to know to what extent is it the ketogenic metabolic state or the addition of drugs. We're not against all parts of the standard of care, okay? We can use immunotherapies that might work much better if you don't have acidification in the microenvironment. Temozolomide might work better, okay? Even a residual part of the tumor that still might be there under metabolic stress potentially could be removed by proton beam therapy, something along these lines, but not the way we're doing it today. The strategy that we have, one shoe fits all, everybody, it's like a chicken's going down the assembly line here, pulling something off them. Okay, cut it out, nuke the guy, give him some temozolomide, give him some steroids. Everybody gets the same thing. What, are you kidding? These people are all different from each other. The metabolism all different from each other. And then they wonder why. Nobody survived. You can't design more beautiful, consistent experiments than this. We have a problem in cancer today. Very hard to reproduce what anybody else is doing, except survival with the standard of care. That's easily reproducible anywhere on the planet because they're all doing the exact same thing, putting the patient at a disadvantage by treating them the way they're doing. Can you believe this? And here's the evidence to support it. You can't feel good. What do you feel good about? Oh yeah, oh God forbid we do something different. Somebody lives longer. Oh my God, we got to keep them on that death curve. What are you kidding me? This is what they're doing. You can see it. No, we're not. Go and look at any survival curve for glioblastoma in any institution across the world, and doing the same Stoop protocol, which is from Roger Stoop. He was the one who developed this, and the success of killing people is magnificent.
Last question.
Brutal, isn't it? Imagine telling somebody that. The guy they think they're doing good in these.
Everybody's dead.
Yeah, and when you tell them that, they don't want to hear it.
Yeah.
Do you see any other specific places where the experiments could be improved the next time around?
Well, I think I think we can certainly. We have to modify the standard of care. It has to be changed if we're going to. Why don't we have enough success from what we call historic controls? That's what we do. These data have been reproduced in clinic after clinic after clinic everywhere. So it's so unbelievably reproducible. So if you have a new therapy, and instead of the median survival of 15 months, the median survival is now 48 months, and you see that on a regular basis, are you telling me that's not something that works? Are you saying now, we can't use those data? What, are you kidding me? And if you have a glioblastoma, what you're going to go to the standard of care? And they always tell the patient, yeah, it's not curable, which is true. But, we're looking at maybe 15 months if you're lucky. A lot of people dying in less than a year. Look at how many people are already dead in less than a year, 9 months. How is that possible? You can keep these people alive. Not all of them, of course. Some of them are real bad. But I think in general, we can significantly improve overall survival, knowing the science and the biology of what goes on in those tumorigenic situations. I know what I'm saying. Prove me wrong. Go ahead. You design the work exactly the way you want it, and I can't guarantee, but I would be very, very shocked if we're not able to increase survival by double. Okay? Prove me wrong. Go ahead. Somebody out there. Let's change the standard of care and see what happens. Okay?
Can't get much worse.
Can't get any worse. Hasn't improved in 100 years. What are you talking about?
I was just curious, what is the argument for all the radiation? What is...
It's revenue.
Is there never at any point something really compelling about doing it?
It's all revenue generation. And when you tell them that, they get upset. And they say, well, why do you not do it? Oh, no, we have to do it. Why? Oh, no, we just do it over and over again. Hospitals make a lot of money on radiation.
So there's nothing you can trace back to that brought this about as being...
Well, they said that if you don't do anything, which is called best supportive care, okay, you got to know what that term is, best supportive care. Make the patient comfortable. Okay, give them Domino's pizza, sugar smacks, and chocolate chip cookies with milk, what happened? They don't live long. They don't live long. Maybe 6 months, maybe 4 months. Wow, let's radiate the guy. Okay, now he's living 15 months. Whoa, big advance. All right. So, but if you don't give him chocolate chip cookies and you put him on metabolic therapy without the radiation, how much longer is he going to live? Aha, that's where you go. And then you start seeing, because the brain will heal itself, the body will heal itself if you give it the opportunity. You're not giving it the opportunity. You know what I mean? Who wants to have their head irradiated, for crying out loud? Right? Oh, this is really smart. Right? We're going to line up and get ready to get our brain irradiated. Jesus Christ. I mean, what are you doing here? This is what they're doing to these people. And they walk in. And then when they're told you have a glioblastoma, they're so wiped out mentally. The family is devastated. What is glioblastoma? Some people have no clue what it is. What is that, Doc? What's a GBM? Well, you better learn real quick what it is, because you ain't going to be around that long. So, and then the family realizes, and then they go into a shell. They go into they don't even want to talk about it. They're so devastated because the people they know who have glioblastoma, like Ted Kennedy, President Biden's son, Bo, John McCain. You have big profile people who have these tumors and they're all dead, no matter how much money they have or what influence they have. Obviously, they couldn't save themselves. So then you get this impending doom that, oh my God, and you have a glioblastoma. What's that? It's terminal cancer, and is it bad? Yeah, it's real bad. What if I do metabolic? No, that's not going to help at all. What do you mean it's not going to help at all? Do you know the science behind that? Did you understand the science? No, I really haven't looked into it. Well, why the hell didn't you look into it and find out? These guys tried it. They're living longer than most of the other people. Where are they on the chart? They're way out here. They're out in this zone. So does that mean it? Yes, that means it's possible to do it. Absolutely, and it will happen when people start realizing how to treat people the correct way. Once they treat the correct way, you're going to get much better results.